Good morning, everybody. Happy Medical Monday. I'm Dr. Heather Hammerstedt from Holist. We are all better together. I am all about getting practitioners from all across medicine, health, and wellness together to form team-based comprehensive health and wellness. And I think patients and doctors and practitioners are stuck in the middle of a system that is not working. We're all putting our hands up and we need to work together to make it better. I love to share what other doctors are up to. You guys know that. Medical Monday is perfect for that. Today I'm really excited to welcome Dr. Eric Larson. He's an anesthesiologist at Michigan State and in Grand Rapids as a private physician. He is also the founder and host of the Paradox podcast, which is really awesome. I wanted him to come on today because he had a great podcast on a couple weeks ago with Dr. Marion Mass, a pediatrician in Philadelphia, who is leading our charge to figure out why we have all of these crazy shortages of medications and supplies that you guys would not believe. And he's going to be able to get us the details about why. And I think you're going to be just as mad as we are when we get through this, and hopefully you will join us, whether you're a doctor or whether you're a patient or whether you're just an interested person about trying to get this problem solved. So we are going to go behind the scenes and figure out what it is like to be working with limited medicines and supplies. And that is what the Paradox podcast is all about. It is all about getting behind the scenes of medicine. And it's a really interesting podcast. You guys should check it out. I'm just waiting for him to join me. I have him adding here, but it's happening a little slowly. So the underlying issue is this. We went into medicine because we love it as doctors, right? We spent most of our 20s sacrificing ourselves in order to learn how to take care of patients. We really want to care for patients. We have a lot of external pressures right now. And let's see here. Hey, Eric, can you comment and I will try to add you again? We want to be taking care of patients. We have a lot of external pressures on us, and that is both from insurers and from payers and from administrators. And as we're going to talk about, from a political system, which has allowed kickbacks to allow hospitals and pharmaceutical in-betweens to cause us to have shortages and cause things that cost a lot more money. Hi there.
Hi.
How are you?
Good.
Good. Thanks for joining. That was pretty slick. The first time around you didn't get on, but it went pretty fast. It's even our first time trying, which doesn't happen that often.
Well, I didn't have my camera, my audio linked up, so
Gotcha.
I guess I didn't want Facebook what's doing. So
Gotcha.
We're all set. I think
Great.
We're good now.
Awesome. So thanks for joining me on this Medical Monday. And it's a little bit earlier for me. I'm over here on Mountain Time and you're on East Coast time. I just finished another night shift and you know how that is, but my night wasn't too bad. I was just talking a little bit, kind of framing the issue a little bit about why we as physicians think this is a really important topic for everyone to understand and for everyone to get politically active about. And I was talking about that great podcast you had with Dr. Marion Mass, and I'm going to tag her on this when we're done so she can weigh in the comments and give us some expertise and maybe some links to things that she's posted and done. And so take a minute and just introduce yourself a little bit and why you're interested in this topic, and then I've got some questions for you.
Well, I'm Eric Larson. I'm an anesthesiologist. I'm a clinical assistant professor at Michigan State University here in Grand Rapids. And I started this podcast about 2-3 months ago now. I'm up to episode 16, 17 will go out this Wednesday. And I wanted just to introduce people to give perspective of what we're dealing with in the trenches, similar to what you're doing right now too, just kind of so people who are non-physicians understand what we're dealing with. And also a way for us as physicians to send out, links and things to people who are interested in this so that they can better understand things. So I do my best.
I'm going to interrupt you and tell you that Dr. Mass is actually watching. So hi, thanks for joining us.
So what I noticed many years ago, actually, after I finished my residency in 2004. And so what I've experienced as an anesthesiologist, we obviously administer lots of medications, lots of them are generic medications. I know you do a lot in the emergency department as well. And certainly over the last, I'd say 5 to 6 years, the amount of shortages we've had of medications has been on the rise. I mean, I don't know, it was about 5 years ago we had propofol shortages.
Yeah.
I'm sure you felt that in the ER.
Yeah.
Uh, and so it was always perplexing to me why we were having these shortages. I mean, this is a pretty advanced economy. You know, you don't ever go to the grocery store and find things missing.
Right.
I mean, occasionally, you know, the price of bananas might go up because there's something that happens, but you wouldn't see shortages, especially for as long as we see. I mean, I think you could explain away, well, there's a fire in a plant and that's why there's no lidocaine for a week or two. But why would you not have access to medications for, you know, 8 months? It's kind of crazy.
Right. And for me, I mean, you mentioned propofol, and for people who may not know what that is, it's a sedative, an anesthetic that we use to help people for surgery or for procedures. And I have another example is that we were like nearly out of epinephrine a little bit ago in terms of like saving
Yep.
people's lives from, you know, cardiac issues. So yeah. I really liked when you alluded to, you know, shortages like being in Africa. So one of my kind of other jobs is I do run a nonprofit called Global Emergency Care in East Africa, doing emergency medicine education. And I hadn't really thought about it that way, but it does feel like that sometimes.
Oh, I'm sure.
Yeah.
I mean, you can imagine if in a world where there's a shortage, the people with the most money are the ones who are going to get whatever it is that there's a shortage of,
Yeah.
right? They're more likely to be
So-
in front of the line, and so this could be the United States.
Yeah, totally. So what can you describe a little bit for us? Like, what is the drug supply shortage, in a little bit more detail about, and then a little bit about what causes it.
Right. So it's a very complicated issue. I mean, obviously with the FDA, that the regulatory body certainly adds extra layers in the production pressures and the difficulty in producing things, right? Like it's a lot easier for many things to produce than when you have less regulations that are going to control the ability to get into the market and produce something. So the FDA has some role in this, but one of the bigger things is the organizations that are sort of the middlemen in medicine now, which I was not at all aware of until I talked to Dr. Mass and sort of researched a little bit beforehand. But essentially, I'm gonna have to go back. We're gonna go back in time to 1920, let's say, just to kind of get a good feel for things. It will be a quick history ride here. Don't worry. So, in 1920, if you think of a hospital as a very small philanthropic building, right? I mean, so it was established by some philanthropists in town. A couple nurses, a couple docs ran this, and it was shoestring budget, right? It was not a very sophisticated business in the sense it was a charitable organization. And so at the time, they were very small hospitals. They don't have much administration. And so their ability to get supplies like medications or medicines, it was very limited. And so their ability to do group purchasing was very small. So they were unable to do bulk purchasing. So what they do is they form these co-ops. So you form like 20 hospitals together, and they will write contracts, and we can get better price on bedpans and sheets and, you know, simple, you know,
totally.
IV fluids or whatever.
Yeah, buy in bulk over lots of different people and spread your prices out. Yeah.
Absolutely. And so exactly. And so then the pharmacies did the same thing, and they also had co-ops they sort of produced, and they called those pharmacy benefit managers. And those were also using insurance companies to help them do bulk purchasing, because lots of insurance companies, it's hard to imagine now, but they were actually very small. I mean, you just insure an area, maybe a couple of counties or something like that initially before they scaled up.
Right.
So you had these group purchasing organizations, which are the ones that the hospitals used, and these pharmacy benefit managers that the pharmacies use. Well, healthcare changed in the 1980s, late 70s, 80s, 90s with the infusion of Medicare money eventually. Healthcare, it was no longer hospitals, now a healthcare system. And so these became very big entities. And so the amount of medications they were buying, everything is a lot more complicated. And what happened is these group purchasing organizations got bigger, as did the pharmacy benefit managers, whether by acquisition or mergers or whatever. And so as they started controlling more of the market, it was more important for a manufacturer of medication or supplies to get into the group purchasing organization. We're just going to talk about the hospital aspect of it, group purchasing organization. So the group purchasing organization would have a formulary that they would sell to the hospital. Say, we'll make sure if you buy all our stuff, we'll make sure you have everything you need to run your hospital, whether it's medications or supplies. Well, after a while, they said, well, there's a membership fee, to be part of her formulary. So you had to pay a certain amount of money as a manufacturer to get onto the formulary. And then, of course, what happens is that price goes up over time and it continues to rise. And as it rises more, the person who was producing one product can no longer compete. They actually have to produce 2 or 3 to meet the margin, because you're making generic medications, let's say, for most part, if you're looking at the medication aspect. And so it's very hard to get into the market if you're just an innovator for one thing. And so before you know it, now you need to do 10 things or 20 things, 20 medications. And so now really the only people who are producing things are very large companies and large plants.
Right. Sure.
So this is unlike most parts of the market. And so what happens now is then you have in the mid 80s, the Safe Harbor Act was passed. So this allowed these middlemen, the PBMs and the GPOs, I apologize for the acronyms for listeners, but they were now allowed to do
the pharmacy benefit management groups and the group purchasing organizations, right?
Correct. And so they were allowed to then charge the hospitals. They would give the hospitals a rebate if they didn't buy outside the formulary. So there were these kickbacks and money that kept going back and forth to these middlemen. So these people who really were writing contracts initially were there to save money. They started making the industry, whether intentional or unintentional, they made it harder and harder for people to enter the market. And so you had less people who could compete. And so you have less competitors.
To make the drugs and to sell the drugs. Yeah.
Exactly.
Yeah.
And so what happens then, that was in 1987. So it takes a long time as the price goes up and up to get access to these organizations. And so it takes a long time to manifest in shortages, because what happens now we enter the 2000s, and now something happens somewhere. There's a fire in a plant or whatever. Mm-hmm. Well, there are only 3 people making something. Whereas, 40 years ago, there were like 100 people who made IV fluids. So now if some big thing happens, it can cause massive disruptions in the market. And the U.S. domestic market also, with the global presence we have, it affects the entire world. So now you have something and then you have certain tax advantages, like, let's say you have less tax you pay if you're in Puerto Rico. And so what happens is lots of these manufacturers, to save money, put all their plants in Puerto Rico. A hurricane comes through, and everybody in the country has no limited access to IV fluids.
Right. Yeah. No, that was something that I'm sure no one outside of the medical world understood happened, that we were literally like out of normal saline in Idaho because of a hurricane in Puerto Rico. I mean, it was crazy. So I'm going to summarize just a second.
Please.
So like when we're talking about the 1920s, we're talking about, small, like my hospital system, this Catholic system, it was probably just a couple of nuns like running theirs. They didn't have enough money. So they grouped together with other smaller organizations so that they could purchase medicines. And then as we see even now, these systems are getting bigger and bigger and bigger. And it ends up that in the 80s, they were able to, these big hospital systems and the big pharmaceutical systems were able to lobby to get in an opportunity to basically corner the market and get kickbacks, is what I'm understanding. And and then this is where we are, and we're now someplace where the market is so small that we can have one problem and we can't react fast enough to make more to be able to provide life-saving medications. Is that a decent summary?
I think that's excellent summary, and it's really, and it affects everybody. This is not the fact that you and I are dealing with trying to find alternatives to medications to treat people. If I'm doing peripheral nerve blocks and I'm trying to use weird local anesthetics, or I don't have access to like Dilaudid, for instance. I mean, and IV fluids, but
we're providing perhaps worse care because we don't have the standard of medications that we're used to using or should be using. And that's where it becomes a patient issue. Absolutely.
Absolutely.
So let's talk a little bit about, so what we've been talking about is like the way that the law was written in the mid 1980s in the Safe Harbor. It seems to me like that was benefiting mostly those GPOs, the pharmaceutical organizations, the middlemen basically, that were purchasing and then purchasing from the pharmaceutical companies and giving to the hospitals, right? So that was So why are we to the place where the pharmaceutical companies aren't mad because they've got a middleman who's taking money, and why aren't the hospitals mad that they have a middleman taking money and that they're providing less resources for physicians to take care of patients? Like what's there?
Right. So I think the easier question to tackle is, let's say, look at from the hospital perspective. Why would they tolerate this situation? Because why would you be a hospital and say, I mean, normal saline, which for the layman is basically salt water that we use. It's sodium chloride and water. It's the easiest thing you could possibly make. You have a filter, and then you make it. But only a few people provide this. So why is it? Why would you, as a hospital, not insist on having other opportunities when you're paying exorbitant fees for this product? Well, the answer lies in the fact that you get a rebate, and it's sort of like, as Dr. Mass always refers to it, it's like a legalized kickback, right? So when you hear these rebates, so if you deviate from my formula from a GPO as a hospital, you're going to sacrifice, say, like $3, $4, $5 million. I don't know the real amount, but it's significant. So you might save money by somehow finding a cheaper source of saline, but you're going to lose in the end. And so it discourages the hospitals from looking
because you're losing your contractual agreement with that GPO
exactly.
to bring you all the other medications, right?
The same thing goes for the pharmacies. Right, and it goes for the pharmacies. And for the pharmaceutical companies, I mean, you can imagine if you look at your, all the sort of things that go into your business model, well, you are paying a fee to get into this, and it costs you some money, but since you're at this point, you're only the big ones are left, right? So you have a competitive advantage over anyone who can come in as a small innovator to make one certain type of drug. And so even though it costs you a lot of money, it creates a giant barrier to entry for competitors. And so it's probably worthwhile to you to have a system like this that still exists. And also, it's the only kind of way it runs at this point. So, when people are looking to fix this, they're looking to try and repeal this law. And I would caution anyone to think that once this law is repealed, it's going to fix everything, because it'll take some time. Right. If once you still have to have people suddenly, start opening these new plants and having chemists, develop new ways of making these medications or whatever, to increase the supply. But it's the first step that you have to do to fix this problem.
Yeah, and proud to say that so I'm the Idaho chapter president for the American College of Emergency Physicians, and I know that ACEP was instrumental in kind of getting that conversation into into discussion, because we passed a resolution as a national organization to support that and lobby for that. So it's exciting. So I know I don't want to get off on too much of a tangent here, but I'm hearing like the echoing of the problem with private physicians and in and out of network issues with insurers. I mean, it sounds very similar to me. It's like you have a small product, you want to provide that as an independent physician. The bigger hospital systems can negotiate lower prices with insurance companies because they have more of a patient population to offer. And then then the independent physicians are getting kind of lost. And so we'll save that for another day, but it sounds awfully similar.
Yeah, it's a good idea.
So how can we as physician organizations, and how can patients, do you think, start working on this problem?
Well, I think the first thing to do is to try and learn a little bit more about it. And so I would recommend going to Dr. Mass's organization, which I think you're going to link to. And
yeah,
I think recommend listening to my podcast, The Paradox, episode 5 is, I think, a good summation. You'll be the smartest person on the block when it comes to these drug shortages. Yeah. And it's important. I think as physicians, we can complain about stuff, but ultimately, a lot of us are employed, and so you can't say too much because it does kind of tip the apple cart a little bit. But it comes down to essentially patient care, and so patients need to know about this and to be outraged. I mean, we're already outraged by the increase in price for simple things like insulin. I mean, things that have been around for years, and that's gone up because of these middlemen. I mean, in large part because of the sort of the regulatory capture and all this problems, which again is probably why the pharmaceutical companies are fine with the way the situation is right now. So I think you just need to contact your representatives. The Trump administration is looking into it. I think they're kind of, my impression is they're sort of concerned about these PBMs, and so maybe they're in the crosshairs, and maybe this law, there's a chance of it dying. The problem is, of course, they have a ton of lobbying money, and so they have millions of dollars that they give. Even in off election years, I think Express Scripts gives a couple $1 million, and so some of the biggest healthcare companies in the country are these middlemen, these GPOs and PBMs, and so there's a lot of money. And without this law and without this they're sort of, neutered. And so they're going to do everything they can to prevent that from happening. So that's the moneyed interest that can only be beaten by large grassroots from patients and physicians.
Yeah, absolutely. I think the patient portion is really important because otherwise it just looks like, a bunch of whining medical system people, you know what I mean? And the other thing I think is important for patients to think about this problem in the context of the bigger healthcare mess is like, I really like to try to educate, my patients and my family and my friends about like what the healthcare costs are and what your bill really is. And when it comes down to it, physician costs are 7 to 8% of the, the overall healthcare system issue. And I don't remember the number on inpatient stays, but it was also like not huge. It was pharmacy and medications. And it is pretty, and the middlemen of administration and layers of bureaucracy and insurance costs and all that stuff. But I always like to say like, hey, listen, you're going to get your bill and I'm going to be 7% of that bill. Right. So like, don't blame this on me.
Right.
But understanding kind of all those complicated pieces, I think is really important because otherwise it's easy to just throw your hat on, some easy, simple solution to the healthcare mix.
Yeah. I think the best thing to say is there's no simple solution to the problem. It has multi-layers and multifaceted, and you can attack one at a time, which is the only way, right? The only way to eat an elephant's one bite at a time, but something needs to be done. But this is one step. But there are all kinds of problems, which it's why you have plenty to talk about.
Yeah. Well, you say we can do one at a time, but I'm an emergency physician and I like to task shift. So I think I will do multiple things in parallel.
Yeah, well, I'm the same way, right? I always joke that I went into anesthesia because I didn't like treating blood pressure over 6 months. I like treating it right now.
Yes.
Same for ER.
Yeah, exactly.
Yeah.
That's great. Well, I really want to thank you for your time this Monday morning for Medical Monday. And please, drop some information into the comments for our watchers and listeners and voyeurs about how to, reach you on your podcast or any other kind of social media that you have so that we can follow along and keep learning about these really, really important opportunities. And I'm just going to say quickly to my audience, thanks for joining. Medical Mondays are always a little bit different than some of the other Facebook Lives that we do. And a reminder to check out Holist for our comprehensive health and wellness teams and proactive care kind of across alternative and conventional medicine. And follow us along at Holist Health on all the social media. And so thank you, Eric, Dr. Larson, and we will talk to you soon.
Thanks so much. Have a good day.
Bye.
Get some rest.
Yeah, I will.